Okay, what's up, guys? So we'll continue along with our OB-GYN practice questions and answers. We finished up with danazol last time. So just to recap danazol. So danazol is a hyperandrogenic drug that can treat endometriosis, but it's not used as much due to its androgenic side effects like hirsutism, weight gain, etc. But it inhibits FSH and LH secretion as well. The next questions will be, what is the best or most effective emergency contraception? And what is the order from best to worst? So we'll just do the top three, the order of best to worst emergency contraception. What are some advantages of combined oral contraception? What are some disadvantages of combined oral contraception? And what is a contraindication of combined oral contraception? So the best to worst is going to be the copper IUD as the best form of emergency contraception, the copper IUD, and then ulipristal, and then levonorgestrel IUD, and then combined OCP. So the top four, I guess, would be copper IUD, second would be ulipristal, and then levonorgestrel, and then a combined OCP. So how do I remember the advantages, disadvantages, and contraindications of these oral contraceptives? So we have some advantages here. I remember it as BOODEH. BOODEH. So those are the advantages. So B, bleeding stops. O, osteoporosis, it helps. O, ovarian cancer protection. D, dysmenorrhea. It helps with the painful menstruation. And E, endometrial cancer. And H, decreases hirsutism. So bleeding, it stops bleeding. Osteoporosis, it helps. Ovarian cancer protection. Dysmenorrhea, endometrial cancer, and hirsutism. So those are the advantages of OCPs. What are some of the disadvantages? So we have hypercoagulability twice, basically, with DVT here, but this is HGT-ED. So that's how I remember it, HGT-ED. So hypercoagulability, gallstones are a side effect of OCPs, triglyceride increases, edema increases, and DVT increases. So the most important, of course, is hypercoagulability. So that's why I have it twice, hypercoagulability and DVT here. So HGTED. Contraindications to OCPs, it's going to be MBH and 35. So MBH 35, that's migraines is a contraindication. So if they have migraines, that's a contraindication for doing OCPs. If they have breast cancer, that's a contraindication because we don't want to increase estrogen in that case. Hypercoagulability, if they already have a hypercoagulable state, or if they're over 35 and they're a smoker. So over 35 and smoking is a definite contraindication to OCPs. So next question is, how long does the copper IUD last? How long does the copper IUD last? And what are the adverse effects of the IUD? So 10 years, the copper IUD lasts 10 years. There's also some that last 3, 5, and 7 years. And it can actually last up to 12 years. PID increases the incidence of. So it increases the incidence of PID within like the first month of insertion of the IUD. And the most common or most specific bug for that is going to be actinomyces. Actinomyces for PID in patients with an IUD. Treatment for pruritic papules and plaques of pregnancy. So treatment of pruritic papules and plaques of pregnancy, that's going to be corticosteroids. What is a snowstorm or a grape-like cluster on transvaginal ultrasound pathognomonic for? Snowstorm or grape-like cluster on transvaginal ultrasound. Next question is, what is the difference between a complete and partial, which kind of gives it away. So difference between complete and partial. What are 3 manifestations of this condition? And what do we want to obtain after treatment of this condition? So this is, of course, gestational trophoblastic disease, hydatidiform mole, and we can have a complete or partial mole. So the difference between a complete and partial mole is that a complete mole is diploid 46XX XX abnormality, and this is all paternal chromosomes, and it leads to absence of any fetal tissue at all. So diploid has no fetal tissue at all, and that's the complete mole. Whereas partial is a triploid, and it does have fetal tissue, but it's never viable. So how I remember that is partial has RTI in it, partial, and that's triploidal. and that's some fetal tissue, but it's never viable. And this will manifest as painless vaginal bleeding, hyperemesis due to the increase in abnormally high HCG. And remember, for ectopic pregnancy, we have the slightly abnormally low HCG, which might be an indicator. So for hydatidiform mole, abnormally high HCG, they may have the hyperemesis gravidarum, and uterine size and date discrepancies. So you must not only follow the HCG down to 0 after treatment with chemotherapy like methotrexate, for instance, but also may obtain a follow-up chest x-ray to rule out lung mets. So we want to rule out lung mets if it is a choriocarcinoma. So name the 3 biggest risk factors for an ectopic pregnancy. So what are the 3 biggest risk factors for ectopic pregnancy? What is the most common location of the ectopic pregnancy? What is a triad of ectopic pregnancy manifestations? And when do we use methotrexate in an ectopic pregnancy? So very important questions. So risk factors would be a previous ectopic as the most important risk factor and most common, having an IUD, as well as PID, because it can cause scarring, and then implantation in the ampullary aspect of the fallopian tubes. So the ampullary aspect of the fallopian tubes is the most common. So previous ectopic, IUD, and PID are the risk factors. Ampullary is the most common location. And 3 manifestations would be unilateral pelvic pain on one side, unilateral, amenorrhea, and also vaginal bleeding. And also, if it is ruptured, the Kerr sign potentially, which is referred pain to the scapula from the phrenic nerve. So that could be the irritation of the peritoneum up to the phrenic nerve, which kind of radiates to the scapula. So you could have the Kerr sign. And also methotrexate is given under a few circumstances. They have to qualify for these things here, and it's if they're hemodynamically stable, if they have an under 5,000 HCG, if the fetus is under 4 centimeters in size, and it also has no fetal heart tones, and also they're willing to follow up. So willing to follow up, no fetal heart tones, under 4 centimeters of the size of the fetus, under 5,000 HCG, and hemodynamically stable. So next question is, what is lochia serosa? Where should the uterus be after delivery? So what is lochia serosa, and where should the uterus be right after delivery? So lochia serosa is a pinkish brownish vaginal bleeding during postpartum days 4 to 10 from the remaining decidual tissue. And the uterus should be right after delivery at the umbilicus. So it should contract down to at the level of the umbilicus. If it doesn't, we're at risk for what? Uterine atony, which can cause postpartum hemorrhage. How much blood is normal in vaginal delivery? So how much bleeding is normal in a vaginal delivery, and how much bleeding is normal in a C-section? What are the 4 causes of postpartum hemorrhage? So what are the 4 causes of postpartum hemorrhage? If oxytocin is ineffective, what do we use next for uterine atony? So that gives away one of the causes of postpartum hemorrhage. So if oxytocin is ineffective, what do we use next? So we can lose 500 mLs typically for a vaginal birth. That's okay. 1,000 mLs for a C-section. Uterine atony is the most common cause of postpartum hemorrhage, and it's also one of the 4, of course. Uterine atony, also lacerations, retained products of conception, and coagulopathy like DIC. So uterine atony, coagulopathy, thrombin disorders, retained products of conception, and also lacerations. And methyl ergonovine, so it's a vasoconstrictor, is used after oxytocin, after manual massage and compression of the uterus is not helping. So then we can give methyl ergonovine. If they're just losing too much blood, the uterus is not contracting down, we've already given manual massage as well as oxytocin. What are the 4 uterine relaxing agents? So what are the 4 uterine relaxing agents? So 4 uterine relaxing agents are remembered by the mnemonic, it's not my time. So I guess the baby's saying it's not my time to come out. So it's not my time. It's going to be indomethacin, that's a prostaglandin antagonist. Of course, it's an NSAID, indomethacin. Nifedipine, a calcium channel blocker, so inhibits the contraction. So calcium enters the cell to lead to muscular contraction. So inhibiting that, we're going to inhibit the contractions of the uterus. Magnesium also offers neuroprotection, so magnesium is also a tocolytic, and terbutaline as well, so it's not my time. So we also should know when we use these. So if they're between 30, so if you're going to delay labor and use a tocolytic, if they're between 32 to 34 weeks, we want to use nifedipine as first line. So nifedipine for 32 to 34 weeks. Before 32 weeks, we can use indomethacin. Roche says indomethacin is first line at that time because it does not at that time lead to premature closure of the patent ductus arteriosus. And then second line would be magnesium sulfate. And magnesium sulfate has the added benefit of being, of course, if they have a preeclampsia, that would be helpful for that, but to prevent eclampsia, but also for fetal nerve protection for cerebral palsy or other disorders. Magnesium is good for that too. But first line, 32 to 34 weeks, you want to use nifedipine as a tocolytic. And then before that, indomethacin with magnesium as a second line. So what does APGAR stand for? What does APGAR stand for? What are the 6 absolute contraindications to induction of labor? What are 2 agents used for induction of labor? So the 6 contraindications to induction of labor, that'll be active genital herpes. So if they have a herpes infection, that can infect the newborn through the birth canal. So active genital herpes is definitely a contraindication. A classic uterine incision, so that one's vertical across the uterus. So even if it is a fan and steel incision on the skin, the uterus could still have a classical C-section incision, and that would be a contraindication. Transmural myomectomy. So if we did a transmural myomectomy for a fibroid, for instance, that would be a contraindication. A transverse fetal lie, so we wouldn't induce birth with a transverse fetal positioning. In this instance, we could do an external cephalic version with a tocolysis, or if they have an epidural in, we could attempt that, but you can't induce labor with a transverse fetal lie. Placenta previa, as well as a prolapsed cord. So what are 2 agents used for induction? That's going to be misoprostol as a ripening agent of the cervix, and Pitocin, so that's oxytocin, that's used as a uterotonic agent to increase the contraction of the uterus. What are 2 complications of premature rupture of membranes? What are 2 complications of premature rupture of membranes? How do we diagnose premature rupture of membranes? And there's 3 ways here. What is the amniotic? What is an amniotic fluid index? So what's the amniotic fluid index and what does it tell us? So complications would be of premature rupture of membranes, chorioamnionitis and endometritis. So infection of the chorion and the amnion and the endometrial layer itself. 3 ways we can diagnose it are a nitrazine test. And for the nitrazine test, you're going to see a pH of over 6.5, which will turn the nitrazine paper blue. So the alkalotic pH of the amniotic fluid in comparison to the vaginal fluid. So the vaginal fluid is typically going to be more acidic, and the amniotic fluid is going to be more alkalotic. So when we have that gush of fluid, it mixes, and when we put that in the nitrazine paper, it's still going to have that more alkalotic pH because you're having way more of the amniotic fluid with that gush, but you're still going to have some mixing, so it will decrease it slightly, but you should still have a pretty alkalotic pH due to the amniotic fluid. Also ferning under the microscope. So you can put the amniotic fluid under the microscope and you see ferning. And also clinically, a pool or a gush of fluid in the posterior vaginal fornix. So that might be what the patient says, or you see that on exam. So pooling of fluid in the posterior vaginal fornix. So the amniotic fluid index, the AFI, is performed by ultrasound to determine how much amniotic fluid they have. So if they're under 5, it's oligohydramnios, and if they're over 25, it's polyhydramnios. So under 5, oligohydramnios, over 25, polyhydramnios. What 3 things define labor? So what 3 things define labor? How do we diagnose preterm labor? What does the LS ratio tell us? How do we manage under 34 weeks or under 2,500 grams? And how do we manage over 34 weeks or over 2,500 grams? So regular contractions. So how do we define labor? Regular contractions over 4 to 6 per hour. Also, we want to see progressive cervical dilation and effacement. So that's regular contractions over 4 to 6 per hour, progressive dilation and effacement. We can diagnose preterm labor with a 3 centimeter or greater dilation, or plus over 80% effacement, and of course fetal fibronectin. So if we don't have fetal fibronectin positive, that means they could still not even go into labor for 7 to 14 days. So fetal fibronectin is a pretty important marker. And also we want to see if they're dilated, so 3 centimeters or greater, or 80 or greater than 80% effaced. Then we consider them a diagnosis of labor. So we also want to see that fetal fibronectin positive. So LS ratio is the lungs to surfactant ratio. Under 2 suggests fetal lung immaturity. So how I remember this is there's just more lungs. So it's really lectin to sphingomyelin ratio, I believe, if I'm saying that correctly. However, I remember it as lungs to surfactant ratio, where there's more lungs and less surfactant, so the lungs aren't ready. So if you have immature lungs, you definitely want to do betamethasone first. So how we manage it under 34 weeks and under 2,500 grams is we want to give tocolytics. And remember, we said between 32 to 34 weeks. If they are, we want to do indomethacin under 32 weeks. Nifedipine, 32 to 34. And under 32 weeks, we want to give indomethacin and second line magnesium sulfate. So tocolytics and betamethasone to mature the fetal lungs, and it takes action over 48 hours. Over 34 weeks and over 2,500 grams, we want to admit for delivery. So 34 weeks is a cutoff at this period here, where we would do either tocolytics and betamethasone, or we just admit them for delivery. So what are Braxton Hicks contractions? What is lightening? And what are the cardinal movements of labor? Braxton Hicks contractions, lightening, and the cardinal movements of labor. So practicing contractions, those are Braxton Hicks contractions. Spontaneous, not associated with dilation of the cervix. So there's no dilation of the cervix when you're having Braxton Hicks contractions. And also Braxton Hicks contractions are felt earlier in patients who have already been pregnant before. So they're multiparous. So because they're able to kind of sense and discern what the fetal contraction is earlier, so they'll notice those contractions earlier. Lightening is the descent of the fetal head into the pelvis, and the mom experiences this as a lighter sensation as there's more room to breathe. So as the fetus gets heavier, it has a lightening sensation where it descends actually more so into the pelvis. And the cardinal movements of labor are engagement. The fetal head engages, and then it descends into the pelvis, followed by flexion of the neck down to the chest, so neck to chest, or chin to chest rather, then internal rotation to make its way through the canal, extension, external rotation, and then expulsion. So engagement, descent, flexion of the neck, internal rotation, extension of the neck, external rotation, and expulsion. So name the 3 stages of labor is the next question, and describe the amount of cervical dilation of stage 1 of labor for active and latent phase. So describe the amount of cervical dilation for stage 1 of labor for active and latent phase. So stage 1 is onset to full cervical dilation, which is 10 centimeters, where the latent is 0 to 4, and the active is more rapid dilation, occurring after 4 centimeters dilation. So I've seen other measurements stating what the difference between latent and active is, but from this resource, it says latent is 0 to 4, and active is the more rapid progression after that, occurring after the 4 centimeters of dilation. Stage 2 of labor overall is delivery of the fetus from 10 centimeters cervical dilation, so the actual movement of the fetus. Stage 3 is delivery of the placenta after that. So a question would be classical C-section history. So this is a small vignette. Classical C-section history on a patient with hypotension, extreme abdominal pain at 34 weeks gestation. So they have a history of a classical C-section. Now they're coming in with hypotension, they're having extreme abdominal pain, and they are pregnant right now at 34 weeks gestation. What do you think this is? That's going to be uterine rupture. So a patient comes in, first trimester pregnant patient. She has di twins, and she's having nausea and vomiting. What do you think the diagnosis would be? First trimester, she has twins, and she is also having nausea and vomiting. What electrolyte abnormality would we see in this patient? And also, what would be seen in the urine? And another question about this, what is the first line medical treatment after lifestyle? So what is the first line medical treatment after lifestyle? Such as ginger, high protein meals, sitting up, increasing fluids. So this is going to be hyperemesis gravidarum. They're going to have a metabolic alkalosis because they're losing all that gastric acid from all the throw up. So metabolic alkalosis with hyperemesis. You're going to have ketones in the urine. So ketones in the urine. And we want to treat with pyridoxine, B6, with doxalamine. So that's the first line medical management after you tried the lifestyle, which we said the lifestyle is ginger, small, high protein meals, sitting up and increasing fluids as well. But the first line medical management is going to be pyridoxine with doxalamine. And you can also do antihistamines, ondansetron, Reglan. Reglan is also good. I saw that given a lot because it helps the gastroparesis of pregnancy too. So Reglan also helps the metoclopramide, Reglan, also helps the gastroparesis of pregnancy. What are the 3 most common times a C-section is needed? So what are the 3 most common scenarios in which a C-section is indicated? 3 most common scenarios are a failure to progress in labor, non-reassuring fetal status, as well as fetal malpresentation, so like breech or transverse fetal lie. Failure to progress in labor, non-reassuring fetal status, like some late decels perhaps, and fetal malpresentation. A couple more questions. What would you think if you have a sudden onset of severe, prolonged fetal bradycardia or variable decel after a previously normal tracing? So severe, prolonged fetal bradycardia or variable decel after a previous normal tracing. What should the provider do? And what are some of the risk factors? So this is a prolapse cord. So if the provider feels a cord on examination, they should not touch the cord nor attempt to push it back in, but rather lift the fetal head with 2 fingers and arrange for immediate C-section. Risk factors for a prolapse cord include placenta previa, polyhydramnios, placental abnormalities like velamentous cord or succenturiate lobe, also low birth weight. So succenturiate lobe is like when the placenta has 2 lobes and it's almost like there's a cord connecting them. So of course that middle cord has a risk of prolapse. And velamentous cord, my understanding is that it's just a part of the placenta where part of the cord has extended out of it. So there's more cord overall, and you have more of a chance of prolapse. Polyhydramnios, there's more room for the cord to move around and therefore get caught below as well. And of course, placenta previa, because if you have low-lying placentation, then the cord's obviously much closer to the cervix, so it's going to be an increased risk. What is frank breech? What is complete breech? What is incomplete breech? What maneuvers can be performed? And when should this be performed? So frank breech is when you have both of the knees extended and both of the hips flexed. So the feet are by the face. So that's how I remember frank breech. Complete breech is when you have the knees flexed and you have the hips flexed. So that's in more of a cannonball position. That's complete cannonball position. And incomplete breech is when you have half and half. So what maneuver can be performed? And how should this be performed? When should it be performed? You can do an external cephalic version. This is done as close to delivery as possible due to the high rates of recurrence. And also transverse fetal lie is an inherently unstable position. So frank, again, is hips flexed and knees extended. Complete is knees and hips flexed, and incomplete is one knee extended and one knee flexed. What is the biggest risk factor for shoulder dystocia? What are 2 complications that can occur in shoulder dystocia? And what are 3 maneuvers that can be done for this condition? So the biggest risk factor for shoulder dystocia is fetal macrosomia, typically from gestational diabetes mellitus. So fetal macrosomia, a pretty large fetus, over 4,500 grams. Brachial plexus injury leading to the Erbs-Duchesne's palsy, which is that wader tip deformity, can occur. And also clavicle fractures. So those are 2 complications when they have the wader's tip deformity, which is when they have their elbow extended, their hand pronated, their wrist flexed, and they're like trying to grasp a tip out the back. And they can also have clavicle fractures if we're trying to pull through. The baby's clavicle can actually fracture. Some of the maneuvers that we can do are the Mick-Roberts maneuver. That's when we do hip flexion and fundal pressure. So basically knees to the chest and also fundal pressure. Opens the pelvis as much as possible. We can do the Woods corkscrew maneuver, which is rotating it 180 degrees. And also the Zavanelli maneuver. This is pushing the fetal head back in and then going right to C-section. And this is, so I remember that is the last thing we do, is Z is the end of the alphabet. So Zavanelli maneuver is the last thing we do before going to C-section. So we can try all these 3 things. So next question will be, when do we screen for gestational diabetes mellitus? When do we screen for gestational diabetes mellitus? Explain human placental lactogen. What are 4 fetal complications of gestational diabetes? And explain the guidelines for glucose testing for gestational diabetes mellitus. So very important questions. So 24 to 28 weeks is when we test for gestational diabetes. Human placental lactogen, HPL, is elevated in pregnancy as the placenta grows, which leads to insulin resistance in the mother, purportedly for the fetus to get increased glucose by keeping it intravascularly for longer. Also remember, growth hormone and corticotropin releasing hormone are increasing the glucose as well. So typically subclinical or undiagnosed beta cell dysfunction that is exacerbated in this case. So they typically have some underlying almost type 2 diabetes, and this just exacerbates the condition because of these natural changes during pregnancy. So complications include fetal macrosomia, of course, neonatal hypocalcemia, and hypoglycemia. I don't know why hypocalcemia, but hypoglycemia, of course, because the baby's used to all this high sugar, and when they get out, they're not having that supply of sugar anymore, so they're going to drop very quickly. And their body's been having to increase the insulin due to all that glucose for a long time, so they have that remaining increased insulin, which then makes them hypoglycemic right away. And also preterm labor. So you do a 50 gram 1 hour to start, and if that's over 140, some say 130 to 140, but if that's over 140, they need a 100 gram 3 hour test. And then you want to get 2 out of the 4 criteria for diagnosis with the 3 hour test. So if at 1 hour they're over 180, if at 2 hours they're over 155, if at 3 hours they're over 140, or fasting they're over 95. And again, you need 2 of the 4 for the diagnosis.